Hey everyone, I'm back. We're going to go briefly over chapter 62, hopefully answer any confusing parts of the slides. This one isn't a very big, only 25 slides, so this should be pretty quick. Embryology, we need to go into that obviously so that we know how these abnormalities happen, but just reading from the book here because this makes a little more sense. The embryology of the abdominal wall. By the end of the 5th week of development, embryo is a flat disc consisting of 3 layers: ectoderm, mesoderm, endoderm. In the 6th week, a process called folding happens. The embryo transforms itself into a cylindrical shape. This transformation is a critical part of the process of closing the abdominal wall. As the embryo folds at the cranial end, the base of the yolk sac is partially incorporated as the foregut, where it later develops as the pharynx, lower respiratory system, esophagus, stomach, duodenum, proximal to the opening of the bile duct, liver, pancreas, gallbladder, biliary tract duct system. Almost done. One more paragraph. The growth of the neural tube causes the embryo to fold at the caudal end, incorporating part of the yolk sac as the hindgut, which turns into the cloaca. And we'll go over that in a few minutes. It is also, it also causes the connecting stalk located at the tail to move to the ventral surface of the embryo, incorporating the allantois into the umbilical cord. The derivatives of the hindgut are the distal part of the transverse colon, the descending colon, the sigmoid colon, rectum, superior part of the anal canal, epithelium of the urinary bladder, and most of the urethra. Okay, so little diagram of all of that. All right. So we are here. So when those foldings don't happen as they should, we end up with defects. So abdominal wall defects cause a distortion of the normal anterior surface. And the 3 most common are omphalocele, gastroschisis, and umbilical hernia, which is a form of an omphalocele. The role of ultrasound is to distinguish between these defects. Clinical management depends on the specific type and severity of the anomaly. So this is probably a repeat for you, but week 8 through 11, the fetal bowel migrates into the umbilical cord with resolution by week 12. A normal embryologic herniation. It allows the bowel to rotate towards the SMA, allows development of the intra-abdominal organs, and failure of bowel to return results in bowel containing omphalocele, covered by amnion and peritoneum. Omphalocele develops with a midline defect of abdominal muscles, fascia skin, resulting in an intra-abdominal structures herniating into the base of the umbilical cord. Okay. So 2 types of omphaloceles. Let's see. Oh, by the way, this table here is really good, puts everything in one place for you to take a look at. And I may have something on the test that is extra credit based on this chart. Wouldn't be filling in the whole chart or anything, but do take a look at it. Maybe filling in pieces of the chart, something like that. And I would give you like matching. It would be matching. So, alrighty. So 2 types of omphaloceles. The liver omphalocele may contain liver within a sac, may contain bowel and liver, and demonstrate a large abdominal wall defect. May contain variable amount of bowel without liver, and they are at higher risk for chromosomal abnormalities with this. Okay. Prognosis varies. The extent of the primary defect, associated structural and chromosomal abnormalities. Perinatal mortality is at 80% or more if there's one fetal abnormality, nearly 100% mortality with chromosomal or major heart defect, 10% mortality if it's an isolated omphalocele. All right. So, yeah. Typical features of bowel containing, shown on external examination, and then a cross section of the omphalocele here. Alrighty, so sonographic findings: central abdominal wall defect with evisceration of bowel. That means like total destruction, evisceration of bowel, or combination of liver and bowel into base of umbilical cord. Color flow imaging may help view the cord in the omphalocele. Membrane, which is peritoneum and amnion, encase the herniated organs. Associated findings may be ascites, polyhydramnios, associated anomalies, diaphragmatic hernia, chromosomal anomalies, scoliosis, amniotic band syndrome. So this is a liver omphalocele, and in this picture here, let me see if it's, I was just hoping maybe it looked a little bit better on in the book, but it's about the same either way. So you can see here's the omphalocele. It is, you can tell this is liver tissue because you've got the echogenic walls, the portal veins, and this very typical look of liver parenchyma. On left is, okay, on the left is sagittal 18-week fetus face down with an omphalocele here. On the right is the same fetus in transverse, plane showing herniation of liver, portal vessels seen within the liver. Okay, omphalocele and Beckwith-Wiedemann syndrome. That is the way it's pronounced according to how I researched it. Thought it was Wiedemann, but I heard them saying Wiedemann. So Beckwith-Wiedemann syndrome reported in 10 to 22% of fetuses with isolated omphaloceles. I have a quick little thing about, I thought I did anyway. Okay. Anyway, I don't, but Beckwith-Wiedemann syndrome symptoms are macroglossia, so an enlarged tongue, organomegaly, cystic and enlarged pancreas, and abnormal kidneys. Reports of late manifestation of characteristic findings after delivery, follow-up through gestation, follow-up scans after birth for fetus with isolated omphalocele to exclude possibility of Wilms tumor and adrenal tumor. I had a really quick little blurb about it. Hold on one. Alrighty, this is it. It's 8 minutes, but I'll put it at 1.25, so it goes a little faster, but I think it's interesting to know. This is so vague. Let's just take a minute and watch this. I don't know if you'll be able to hear it, so I turned on closed captions. Okay, so there you go. But for our purposes, we're looking for omphalocele and enlarged tongue and so forth. So I'm going to go past this gastroschisis. Periumbilical defect, usually located on the right of the umbilicus, opening in the abdominal wall with herniation of bowel, infrequently stomach and genitourinary organs, rarely rarely liver. The defect is small, 2 to 4 centimeters next to the umbilical cord, elevated AFP. Coexisting anomalies are rare. Intestinal atresia or stenosis may occur. Ischemia, compression of the mesenteric vessels, or bowel torsion may cause bowel perforation or meconium peritonitis. So, abdominal wall defect, so there's no covering on this. With herniation of bowel defect is to the right of the normal cord insertion. Greater than 50% of the fetuses with ischemia and gangrene of the bowel died. Infants with uncomplicated gastroschisis have excellent prognosis, 92%, surgical repair usually within hours of delivery. 10% will have hypoperistalsis syndrome. So what you would be looking for would be free-floating herniated small bowel, large bowel, stomach, gallbladder, pelvic organs, bladder may be involved. Edges of the bowel are irregular and free-floating and may be mildly dilated, and walls thickened, no covering membrane. So that's, I saw something on here I wanted to go back to. The differences between omphalocele and gastroschisis. We'll go back to that. Right of the para-umbilical defect of abdominal wall to the right. Hydronephrosis, bladder deviation, and exstrophy may be observed. Severe body wall defects may be seen in gastroschisis with secondary band formations. So differentiation here is sonographer should investigate the following to differentiate an omphalocele from gastroschisis. Look for the presence of the membrane. Gastroschisis does not have one. Look at the umbilical cord. The cord goes through the omphalocele, where gastroschisis is found to the right of the cord. Determine which organs are eviscerated. Determine whether the bowel is normal in texture, and look for other anomalies because omphaloceles often occur with chromosomal abnormalities. Okay. Note umbilical cord separate. Okay, so it's a little difficult to see, but I was kind of hoping that we would get a better picture. But by bowel dilatation, gastroschisis with small bowel herniated on the left, and bowel dilatation and obstruction shown in fetus with gastroschisis at 29 weeks. Note haustral markings with obstructed bowel. Okay. Amniotic band syndrome. All right, so really, I hope you guys are looking at the book. There's so much more information in the book than there is in these slides. So amniotic band syndrome leads to entrapment of entanglement of fetal parts by sticky chorion. So basically what happens here is the chorion and the amnion, the two layers that make up the fetal membranes, separate. The amnion comes away from the chorion, and it creates bands, and the bands can wrap around body parts and cut off circulation to those body parts. So body part could be a finger, a toe, an arm, the umbilical cord. If it does that, if it cuts off circulation to the umbilical cord, then you're going to have fetal loss. But the chorion is apparently sticky, so it causes amputations or random defects in random sites. So it can cause severe craniofacial defects, internal malformations, amputations, limb restrictions, associated anomalies, limb, cranial, face, thorax, spine, abdominal wall, peritoneum. If they know about it, they can actually release the part that's entrapped, which is this cute little video here. So important to get to, if you can see that early on, you might be able to save the baby. All right, bladder and cloacal atrophy. Bladder atrophy is a defect in the lower abdominal wall and anterior wall of the urinary bladder. Let's get back to the book. This baby here has secondary amniotic band rupture and all of this. Um, so the everted bladder becomes exposed on the lower abdomen wall. The defect could be mild or severe with an omphalocele, inguinal hernia, undescended testes, anal problems. Local extrophy is rare and more complex, occurring early in development in primitive gut and primitive cloaca, persistent cloaca, and results in estrophy of bladder in which two hemibladders are separated by intestinal mucosa. I want to share something I found about that with you. So first, let's just define the word cloaca. I guess I've been saying it wrong. It's cloaca. It's a common cavity at the end of the digestive tract for the release of both excretory and genital products in vertebrate, except most mammals and certain invertebrates. In a human, it's I believe that it kind of disappears. It looks like that little tail that we have. So if we look at embryology, so so we have this cloaca when we're developing, but it divides into its different parts, and then you no longer have it. It's in embryology that you're having this, but people can have it divides. It divides into you have this, but then it divides into the rectum and in females, both the vagina and the um, urethra. But sometimes there can be defects where they don't divide, and it's one common opening. So it's called a persistent cloaca. They don't go into it much in the book, but just so that you have a more concrete idea of what it is. There's tons of videos on it. I was just looking for something tiny, like a little 1 minute explanation. Well, that's pretty amazing. So that's what this is referring to, right? Let's get back to the book. So your normal bladder will not be visible, soft tissue mass seen on the anterior surface of the lower abdominal wall. So herniated cloaca with a urinary bladder. Here. All right, on to pentology of Cantrell. Pent is 5. I'm sure you all know that. Pentagon, pentagram. So there's 5 associations with this syndrome. Reading from the book, the pentology of Cantrell is rare and is associated with a cleft distal sternum, diaphragmatic defect, midline anterior ventral wall defect, defect of the apical pericardium with communication into the peritoneum, and in internal cardiac defect. So this baby postmortem examination shows a large omphalocele with evisceration of the liver, spleen, and a major part of the gastrointestinal tract, and the arrows indicate the heart covered with skin. So association of the distal sternum, all of these things that we just read. Ectopic chorditis is exposed heart, and it presents outside the chest wall through a cleft sternum. So that's what this is showing. The cleft sternum is partial or absent without ectopic chorditis, typically superior or total cleft, heart beating against chest without sternum to protect it. Okay. Then you've got what's called limb-body wall complex. And I wanted to look more into this because it just isn't very clear to me from reading what exactly it entails, but it is, according to the chart that I told you I might do some matching for extra credit, it is 100% lethal, but no risk of aneuploidy. Multiple anomaly conditions, ZAR complex defect with ventral wall defect, close attachment to placenta, cranial defect, scoliosis. So this is what a normal baby looks like with an attachment. This is limb-body wall syndrome. So this baby is attached directly to the placenta. So this is suspected if a short or absent umbilical cord is seen at the time of your ultrasound, if the baby is in a fixed and awkward position throughout the scan, or if there appear to be any abnormalities of the face or abdomen. So that's really all. It's not going into much detail. Amnion does not cover the umbilical cord, normally extends as a sheet from margin of umbilical cord, continues with the body, wall, and placenta, left side wall, defect 3 times more common. All right, that's it. That is all there is to this. So I will post to YouTube and you can take a look. Thank you.